Hi, my name is Virginia. I'm with University of Miami. I have a case report to present today. So I'll go ahead and start. The case was about epiploic appendagitis. So it's a relatively rare cause of abdominal pain. The incidence is like 2 to 7% of patients suspected to have acute diverticulitis, and about 0.3 to 1% of patients suspected to have acute appendicitis, and it just ends up not being that. The cause is just secondary to an ischemic infarction of the small fat-filled serosa covered outpouchings on the external surface of the colon, projecting to the peritoneal cavity. We call it epiploic appendage. And usually it's caused by torsion if the appendage is kind of long and large. Or it could also be due to spontaneous thrombosis of the central draining vein of that epiploic appendage. Usually it can present with abdominal pain at the location of the infarction. It's actually more commonly on the left side, although our patient presented with right-sided pain, presents with just vomiting, sometimes low-grade fever, leukocytosis, like infectious signs, elevated inflammatory markers. And, our case is just epiploic appendagitis, which we initially thought was acute diverticulitis based on imaging. So this was a 32-year-old guy. He came in with right lower quadrant pain. He said it was progressive in onset within 3 days. He described it as sharp. It didn't radiate anywhere. It was 8 out of 10, initially intermittent and then constant. It had no relationship with food intake. He had nausea as well, but he denied any fevers, chills, or any change in his bowel habits. We did a CT abdomen, and the initial read, it was with contrast, was acute inflammatory process or free fluid, which may be secondary to diverticulitis. But when I saw the patient, I've seen appendicitis and diverticulitis before. He didn't look as sick or in severe distress as usually I see appendicitis and diverticulitis patients. So we were like, let me just re-review this imaging with surgery, because it's just not, with radiology, because it wasn't adding up to me. So went there, and after they revised the imagings, they actually diagnosed epiploic appendagitis. The revision of the imaging, they actually described this round to oval fat shaped density with periappendageal fat stranding, which we can see on the imaging right there with the arrow. General surgery had already been consulted because we thought it was diverticulitis versus appendicitis. And then they also came with us to review the imaging, and they said, yeah, this is epiploic appendagitis. So we actually just gave him ibuprofen, and the pain completely resolved. So I guess what I learned from this is just a self-limiting condition. We treat it conservatively. We want NSAIDs. We can give opioids if needed, but per what I was able to research, the best treatment is just being very conservative with it, because it will usually resolve on its own. They only do surgical management if they do conservative and it does not improve at all. Historically, it has been diagnosed as diverticulitis or appendicitis. But, it just requires more just having clinical judgment and seeing the clinical picture per se, and seeing if it actually adds up what we find on imaging. The only thing with this is that abdominal imaging is what diagnoses epiploic appendagitis. So it's a little bit hard to diagnose it unless you have that thought behind your mind that this could exist. So I just think just knowledge of this uncommon cause of abdominal pain is important, so we don't over-treat patients that actually just have a self-limiting condition. And that would be it for my presentation. I'm happy to answer any questions.
Alrighty, great job. So is there any predisposing factors in patients for appendagitis?
So it's just because it's just an outpouching that develops normally in people. What I read about it is just if the outpouching ends up being large, it just will predispose to torsion in these patients. So it's just the size of it.
And if a patient did have to have surgical management, are they going in and taking out a group of appendages, or are they just taking out the one that's affected? How does that?
But the surgeons told me it was the one that was affected, or anything that they found was at risk, they would probably remove it as well.